Thank you for that introduction. I'm very happy to be here today to talk about newer and upcoming antiretroviral drugs for the treatment of HIV infection. This is a very interesting topic now, despite the fact that we have over 20 drugs, most of which are highly efficacious in managing HIV. It's very gratifying to see that additional drugs are becoming available to try and make treatment simpler and more effective for HIV-infected patients. Let's get started with our presentation today. This is a picture of the cover of a book that Dr. Lamb, who is in fact pictured on this slide, tried to sell in our clinic at Duke University back in 1994 and 95. He had purportedly found the cure for HIV and was offering it to our patients along with this handbook about how to succeed in curing HIV, with the proviso that he would take half of the money that we received from selling his products and we would be welcome to have the other half. This is obviously a ludicrous thing for him to do. In fact, it's actually a rather evil thing since he was taking advantage of people whose situations were quite desperate. Our treatment back in the early 90s was quite inadequate. Patients would extend their lives, but very few, if any, were able to fully suppress virus. And in settings like that, where people have what is generally a fatal disease for which treatment options are imperfect, it opens up the door for people who are trying to take advantage of them. And I've found his behavior to be quite despicable, and needless to say, he was summarily dismissed from our clinic, never to return. So now we find ourselves some 18 years later in an entirely different situation. This slide shows the approved antiretroviral agents as of the summer of 2012. And you can note that from 1994 to 2012, a rather extraordinary compilation of many outstanding antiretroviral agents has made its way to the market. And this list is further extended by the approval in 2011 of rilpivirine, which has also been formulated into a single tablet fixed dose regimen of Tenofovir, FTC, and rilpivirine, offering another one pill once a day option. And in 2012, a third one pill once a day option becomes available with the approval and licensing of the integrase inhibitor elvitegravir, the pharmacologic booster cobicistat, combined with Tenofovir FTC and what is currently referred to as the Quad, the first single-tablet regimen using an integrase inhibitor. And I'd like to spend some time today talking about the elvitegravir combination tablets and showing some of the data that has helped us be quite excited about this addition to our treatment regimens. I think you can get the sense from the last slide that one of the things that has begun to happen in HIV care is the attempt to co-formulate medications to reduce the number of tablets patients have to take and to simplify and synchronize treatment regimens so that patients are more likely to be successful with their therapy. At present, we have the very popular Tenofovir FTC efavirenz single-tablet regimen. As I mentioned, we have a rilpivirine-containing single-tablet regimen, and the addition of the integrase inhibitor elvitegravir represents the third single-tablet regimen, but more are to come. There will be a combination, as we'll soon see, that uses a prodrug of tenofovir to simplify treatment and potentially to diminish adverse events associated with the drugs. And then a third integrase inhibitor called dolutegravir is being formulated into a single tablet regimen with the nucleoside combination of bacavir and 3-TC, and that's projected to be available sometime during calendar year 2013. In addition to these complete single-tablet regimens, other co-formulations are being put together that take advantage of cobicistat as a pharmacologic booster, and then the tenofovir prodrug GS7340, as I'll show you, represents a potentially attractive target for other co-formulations, including with FTC. And so this trend towards simplifying therapy by using combination tablets, I think, has been quite well received in the patient population. But I think it's also true that the cost of antiretroviral therapy, given the numbers of people that are on therapy and the numbers of people that are yet to be diagnosed and will need to be on therapy, have become a very significant issue, especially in this era of budgetary restraint. And so I think the potential for generic drugs to have a major impact on antiretroviral therapy almost certainly will become more and more relevant as we move forward. The single tablet regimen in at least one study, this by David Bangsberg, appears to be associated with better adherence and higher rates of virologic suppression. In this slide, the orange bars represent the adherence rates for persons who really represent some of the most difficult to treat patients. These are persons living in San Francisco who are living in either marginal housing or in some instances are actually homeless. And yet you can see that the proportion of people with good adherence is actually surprisingly high, particularly with the single tablet regimens. Now, the NNRTI-based and protease inhibitor-based regimens depicted in the blue and gray boxes are somewhat less likely to have high levels of adherence. But it's worth noting that the regimens to which these were compared are some of the older regimens, and perhaps these estimates are not quite as robust as they might be for the other regimens. Nonetheless, I think these kinds of data and the very high suppression rates we see with single tablet regimens have established them as a very favorable way for us to go with HIV treatment. So at this point, I think it's fair to say that as it relates to how the drugs are administered, there seem to be two different pathways forward. One is the use of the co-formulated drug, the single tablet regimens, the simplicity, the ease of use, the good acceptability by the patient population, the high rates of virologic success. But this runs into economic uncertainty as budgets are flat or perhaps even diminishing, and the availability of generic drugs as a cost-saving methodology, in fact, suggests that it may be necessary to break up these single tablet regimens and use generic drugs wherever possible. Taking a look at the likely, although these are not necessarily completely accurate, but the likely patent expiration for the various antiretroviral agents, the one that I think has many people particularly interested to see how this will turn out is in 2013. The current patent on efavirenz is expected to expire. Now, there's likely to be legal action to extend this, but if, in fact, efavirenz becomes generic in 2013, this is obviously a central drug to successful antiretroviral therapy in 2012, and it may well be that our single-tablet regimens will start to be broken up if the generic version of efavirenz is available at a significantly lower rate. I think we'll have to wait and see what happens. Nonetheless, while there are some currently available generic drugs, they don't represent the drugs that are now considered to be the preferred treatment options, and it won't be until efavirenz becomes generic that we'll really be facing a situation where generics may become an important and very relevant part of our drug selection process. And we'll have to balance the advantages in terms of adherence and treatment success rates of single-tablet regimens against the potentially large cost savings that could be afforded by the availability of generics. At the recent World AIDS meeting, Dr. Michelle Walensky presented one model that suggested the amount of money that might be saved by switching to generics over the next several years could represent hundreds of millions of dollars. And clearly that will be important as we try and figure out the best way to treat the more than 1 million HIV-infected patients that are presently living in the United States. Well, let's move on to some actual drug data now rather than just talking about projections and strategies. And let's look at the elvitegravir-based regimens that are currently referred to as the Quad. These were recommended for approval by the FDA Antiviral Therapy Advisory Committee by a vote of 13-1, and the FDA has until the last week of August of 2012 to make a final approval or to turn the drug down. Almost certainly the drug will be approved by the end of August of 2012. Included in the Quad is a new booster of protease inhibitors, and in this case, integrase inhibitors. This drug is referred to as cobicistat. It's related to ritonavir, our current pharmacologic booster, but has some differences such that its ability to be co-formulated with other drugs appears to be a favorable characteristic. And finally, in 2013, it's expected that the third integrase inhibitor, dolutegravir, will be approved, and it will include another co-formulation, this time with the Bacavir 3TC. Let's look at some of the data behind these drugs, because I think there is considerable excitement, and I want to share with you the data that underlies this excitement. First, presented earlier in 2012 were the results of the Gilead-sponsored 236-0102 study, in which the standard of care, Tenofovir, FTC, and efavirenz, was compared to the new so-called quad pill, which consists of elvitegravir boosted by cobicistat and combined with tenofovir and FTC. This was a 1-to-1 randomization. Patients were stratified by high viral load or less than 100,000 copies of RNA, and then followed to judge whether or not the new treatment, referred to as the Quad, would be non-inferior to the current standard of care, tenofovir, FTC, efavirenz. The primary endpoint were the proportion of patients with viral load less than 50 copies at week 48, using the FDA snapshot analysis with an intent to treat design, and the non-inferiority margin was designated at 12%. That is, the lower bound of the 95% confidence interval would need to be less than 12% in order for non-inferiority to be established. Here are the results at week 48. In the orange bar are the proportion of patients less than 50 at week 48 in those randomized to the Quad or the elvitegravir-based therapy. You can see it's 88%. The standard of care regimen, efavirenz, FTC, and tenofovir, 84%. These numbers are not significantly different from one another, and non-inferiority was established. It's also interesting to note the proportion that were not considered to be virologic successes are illustrated in the next two sets of bars. Importantly, the virologic failure or non-suppression proportions were exactly the same between the Quad and the efavirenz-based therapy, 7%. And so the difference really was in persons who were missing week 48 data, either having been lost to follow-up, having discontinued therapy because of adverse events, or having other reasons for missing the week 48 cutoff. If you do a plot as seen on the right-hand side of this slide, showing this 3.6% difference between the two treatment arms, and then the 95% confidence intervals for the difference, you can see that those confidence intervals cross the zero line, which means that that establishes non-inferiority. And it appears that the Quad arm has a somewhat more favorable outcome proportion, although these two proportions, 88 and 84%, are not statistically different from one another. This next slide looks at treatment differences by various subgroups in that same study using the same technique as was just seen on the previous slide. One has to look at the horizontal line, and if the line intersects, crosses the vertical dotted line, then that means that there's no significant difference between the two, and you can see that the only place where there might be a whisper of a difference is that persons aged greater than 40 appear to respond somewhat better to the quad than to the efavirenz FTC tenofovir arm, and also down in the baseline CD4 population, those greater than 350 cells, it's right at the margin of being statistically significantly different. But I think basically what this slide shows is that irrespective of the category, it looks like the quad was non-inferior to the standard of care efavirenz-based treatment. The next slide shows the CD4 differences. You can see at week 48 in the quad arm, the increase in CD4 cells was a mean of 239, and in the efavirenz-containing regimen, it was an increase of 206. This is a statistically significant difference favoring the quad, but clinically probably not meaningfully different. Now, one question that arises with new therapies is often, does the drug work in our most difficult, most challenging patients, those with high viral loads and low CD4 counts? And so sub-analysis is virtually always done to look at the proportion of patients with baseline viral load greater than 100,000 copies and baseline pretreatment CD4 count less than 350. And you see here the quad in orange, the efavirenz-based regimen in blue. There's no meaningful difference in outcome for any of the categories favoring either efavirenz or the elvitegravir-based quad. So the treatment seems to work at high viral loads, low viral loads, high CD4 count, low CD4 count, which of course is quite reassuring. Here's the adverse event profile. The adverse events themselves are listed in the far left-hand column. Interestingly, those that have either an asterisk or a caret or a pound symbol represent those in which there's a statistically significant difference between the two. And as we look at this, the first one that comes up is nausea, and we see that 21% of those on the quad reported at least some degree of nausea, grade 1 or higher, mostly grade 1, compared to 14% in the efavirenz-containing regimen. So it appears that the quad, the elvitegravir-based therapy with cobicistat, does have more nausea than do patients receiving efavirenz. On the flip side, persons on efavirenz are well known to have certain central nervous system adverse events. So in this case, abnormal dreams were noted in 27% of those on efavirenz, compared to 15% of those on the quad. And again, this is a blinded study, so neither the patient nor the investigator knows which drug people are on. And then looking at insomnia, again, the significant difference with more efavirenz patients complaining of insomnia compared to those on the quad. Dizziness, again, 24% reported in the efavirenz arm versus only 7% in the quad. And rash, a well-known non-nucleoside reverse transcriptase inhibitor class effect was seen in 12% of those on efavirenz versus 6% of those on the quad. Again, a statistically significant difference. One category to note, no difference is the category depression, where 9% of the quad and 11% of efavirenz patients were found to have some degree of depression. We have associated in the past efavirenz with depression, and at least in this study, it didn't appear that an alternative drug was any less likely to be associated with depression than was those receiving efavirenz. Another issue with efavirenz-containing regimens is the perturbation of the lipid profile, often with significant elevations of lipids so as to create an unfavorable cardiac risk profile. Here we see the differences, again in orange, in the quad compared to the efavirenz-containing regimen in blue, and it's notable that there's significantly greater increase in total cholesterol, LDL cholesterol, HDL cholesterol between the two drugs, with the lesser changes being seen with the quad and the greater increases being seen with the efavirenz-containing regimen. There was no difference in triglycerides. Also of note, the HDL or LDL to cholesterol ratios did not differ between the two arms, although the absolute increases in the various lipid subsets were greater in those receiving efavirenz. Now, one factor that we have previously noted but haven't really paid much attention to that's becoming more often discussed is the fact that some of the antiretroviral agents are associated with a rapid, small increase in serum creatinine, which affects the estimated glomerular filtration rate or the estimated creatinine clearance using our standard formulae. So here is the change in measured serum creatinine comparing those in the quad in the orange line to those who received efavirenz in the blue line. And you'll have to make sure you attend to the scale here because the absolute change in creatinine over the period of observation is only 0.1 milligram per deciliter. So this would be, for example, a creatinine that might go from 1.1 to 1.2 or 0.8 to 0.9. Nonetheless, those receiving the boosted elvitegravir treatment did experience a rapid increase over the first 2 weeks in serum creatinine that is almost certainly the consequence of changes in secretion of creatinine rather than actual impact on the glomerulus and an actual change in renal function. So this is to be expected. It's modest. If the change is greater than 0.3 milligrams per deciliter, that may represent a more significant change. And certainly in someone who's also receiving tenofovir, one needs to pay attention to the level of serum creatinine. But just be aware that if you're using elvitegravir cobicistat, it is associated with a small but consistent increase in serum creatinine of about 0.1 milligrams per deciliter related to secretion of creatinine. Now, that's the results comparing the quad to an efavirenz containing a 3-drug fixed-dose combination regimen. What about compared to other recommended initial treatments for HIV? Well, here's the 103 study, which compares the quad to a boosted Sanovir regimen. And I think this one's particularly interesting because now we're going to also be able to make at least some inferences about the booster itself, because Sanovir in this trial is boosted with ritonavir, a drug we've used for a long time to influence pharmacologic parameters, and it's going to be compared to cobicistat as a booster. And here are the 48-week results, again using the same analysis methodology. In this study, 90% of persons on the quad, the elvitegravir-containing regimen, are suppressed to less than 50 at week 48. 87% of those receiving a ritonavir-boosted Sanovir coupled with tenofovir FTC are suppressed. And again, the virologic non-suppression rate is absolutely identical between the two arms, 5%. And the actual difference is contained within those who do not have week 48 data for a variety of reasons, adverse events included. And again, if we make our 95% confidence interval plot, you can see that the line crosses 0, and therefore the treatment, the new regimen, the quad, is non-inferior to a Sanovir ritonavir boosted combination, one of the preferred DHHS and IAS USA guidelines treatments. Here again are the breakdowns by the various different categorizations, and you can see that there's no difference irrespective of category. The dots in general seem to favor the quad, but because the 95% confidence intervals consistently cross the 0 line, there really is no statistically significant difference between the quad and the boosted Sanovir regimen. Here's a breakdown based on high and low viral load and high and low CD4 count. And again, you note there's no drop-off in efficacy in those with high viral load and low CD4s compared to those with CD4s greater than 350 and viral load less than 100,000. What we don't see here, or in the previous slide, was the less than 50 CD4 population considerably smaller, but that's an interesting group to compare, and I think we'll have to wait for the publication of the paper in order to examine that more closely. But based on these data, it doesn't appear there's any diminution in efficacy among those with higher viral loads or lower CD4 counts. Here are the laboratory outcomes in the two arms. You can see there's really no difference except in hyperbilirubinemia, which is a well-known event in persons receiving adasanavir, particularly ritonavir-boosted adasanavir. So if one uses any grade of hyperbilirubinemia, more than half of the persons randomized to receive adasanavir had that adverse event, while only 1% in the quad arm, obviously quite a different outcome. Should stress, though, that hyperbilirubinemia has no pathophysiologic consequence. And here, looking at adverse events, side effects, if you will, between the two arms, you again are, it's quite notable for no difference between the two arms, except that icterus was more common in those receiving ritonavir-boosted adasanavir. Interestingly, in this study of the quad versus ritonavir-boosted adasanavir, rates of nausea were identical. And here's the lipid profile. You'll recall from the slides we looked at just a few moments ago that the quad had less impact on lipids than did the efavirenz-based regimen. Here now comparing the quad to adasanavir, it's remarkable how little difference there is. Total cholesterol is 10 versus 8 milligrams per deciliter increased. LDL is exactly the same, 11, increase of 11 milligrams per deciliter in both arms, HDL 6 and 5. It's really only the triglycerides that ritonavir-boosted adasanavir has a larger effect. So really very little difference in lipid parameters. And adasanavir, of course, is one of the protease inhibitors that seems to have the least impact on lipids from the class. And finally, again, the serum creatinine, the same observation that we saw before, about a 0.1 to 0.12 increase in measured serum creatinine related to changes in secretion of creatinine. But in this case, in our comparator arm, the adasanavir also has some degree of the same effect. And although the overall impact is lesser at 0.8, again, these are marginally different from one another, and really the clinical significance of this appears to be minimal to non-existent. So I think the information we have so far on the quad is quite promising. It looks like it's going to be a nice new addition to our treatment options, especially for treatment-naive patients, which is where most of the research has been done. It will be another one pill once a day option and appears to have some advantages over other one pill once a day options. Will be interesting to see how this all comes out as FDA approval is secured and the drug begins to be used. Let's change gears just a little bit and talk about persons who aren't starting therapy for the first time, people who have been on therapy before and may have resistance, or alternatively, those who are starting therapy for the first time but have become infected with a virus that already has some resistance. And this is not a rare phenomenon. Here's the most recent data. This is looking at the prevalence of transmitted HIV drug resistance in the United States between 2006 and 2009. So this is the proportion of people that are getting infected with a virus that's resistant to at least one drug. And you can see in the far left bars here, it's all cases with genotype sequences. And you'll note that the overall about almost 16% of persons with new infections have viruses that have resistance to at least one drug. So about 1 out of every 6 new infections include some degree of resistance in the new infection, and those with more recent infections, the number is perhaps even a little bit higher. So resistance is not just a thing to worry about in people who fail. It's something you may have to deal with up front, and anyone starting therapy needs to have a resistance test before treatment is initiated. One of the things that I think is going to help us deal with resistance are improved new therapies. And dolutegravir, the third of the integrase inhibitors, and I note on this slide integrase is misspelled, but nonetheless, this so-called second-generation integrase inhibitor offers the opportunity to treat viruses that have some degree of integrase resistance. This is quite uncommon in transmitted resistance as yet, but likely over time as the integrase inhibitor class is used more frequently, will be seen with some increased likelihood. But let's take a look at dolutegravir, because this is the other new drug that's about a year from licensing at the time of my recording this presentation. It is a integrase inhibitor, an HIV-1 integrase inhibitor. Like elvitegravir, can be dosed once daily, but unlike elvitegravir, it does not require pharmacologic boosting. So this is likely to represent something of an advantage. One of the issues that occurs with elvitegravir and the use of cobicistat as a booster is the booster effect is mediated through inhibition of the cytochrome P450 enzymes, primarily the so-called CYP3A4 isoenzyme, which is one responsible for metabolism of many drugs. And as a result, someone on the quad, the cobicistat-boosted elvitegravir regimen, introduces the potential for significant drug-drug interactions, much like we've learned to deal with in persons receiving ritonavir. Dolutegravir can be dosed once daily without the need for a CYP3A4 inhibitor, and so drug-drug interactions are going to be much less of an issue, probably making it very similar to raltegravir, our current integrase inhibitor, which is quite an excellent drug, although it does require twice-daily dosing. Dolutegravir appears to have very predictable pharmacokinetics from patient to patient, has a high peak versus IC95 and a high trough versus IC95, so it's a very potent drug with a considerable margin of efficacy based on its PK characteristics. When dosed twice a day, it appears that it will retain activity against viruses that have developed resistance, many viruses that have become resistant to raltegravir and elvitegravir. When dosed once a day, it's highly active against integrase susceptible viruses that do not have resistance. The first data that was presented to show efficacy of dolutegravir was the so-called Spring 1 trial. This was a study of about 50 patients, each in 4 different arms, a total of 200 patients. The control arm received efavirenz and 2 nucleosides. The dolutegravir arms consisted of 3 different doses, 10, 25, or 50 milligrams given once per day. And you can see here actually 2-year follow-up data showing that those who got efavirenz, about 72% were suppressed. As many as 88% were suppressed if they got dolutegravir. Similar to what was noted in the previous drugs, there is that about 0.1 milligram per deciliter increase in serum creatinine that's felt to represent an issue of secretion of creatinine and not really a renal dysfunction event. But this 2-year data looks very promising for dolutegravir. The doses that were used, 10, 25, or 50 milligrams, compared quite favorably in outcome to efavirenz. And in particular, if you look at the column dolutegravir 50 milligrams, there were no virologic failures among the 51 patients who received that dose. The Spring 2 study, the next follow-on study, if there's a phase 3 randomized trial, these data were recently presented. This combined dolutegravir with either tenofovir FTC or abacavir 3TC and enrolled over 400 patients in each of the 2 arms. Dolutegravir being compared to the standard efavirenz therapy, and dolutegravir being compared to raltegravir. And at 48 weeks, 88% of those on dolutegravir, 85% of those on raltegravir were suppressed to less than 50 copies. Truly outstanding numbers. Very well tolerated drug, 2% withdrawal rates due to adverse events, and additional studies are underway. This is a very promising drug, and these initial data presented in the summer of 2012 generated quite a bit of enthusiasm, and we're looking forward to more complete data over time and potential licensing of this drug in 2013. The next drug, really the last one I want to talk about in any detail, is a prodrug of tenofovir. Now, tenofovir is a nucleotide reverse transcriptase inhibitor that's really become one of the central drugs that we use for treatment of HIV. Almost all persons initiating therapy start with tenofovir, but it does have some potential toxicities, including renal toxicity and bone metabolism issues with loss of calcium from bones. And so an attempt to improve on this drug is being made with GS7340. GS7340 is actually a prodrug that gets into cells in high concentrations while remaining in low plasma concentration. So here you see the efficacy of the drug compared to tenofovir. This is the EC50, the concentration required to inhibit 50% growth of the virus, different sites, the M22 cells, peripheral blood mononuclear cells or macrophages, and you can see the EC50. The lower the number, the more active the drug, and the EC50 for GS7340 compared to tenofovir is very much enhanced. And so this is a highly potent drug, especially when it concentrates within various cells of the immune system. A dose-ranging study looked at doses of GS7340 ranging from as low as 8 milligrams up to a high dose of 40 milligrams, and this compares with tenofovir given as 300 milligrams. And you can see that the effect in terms of virologic reduction for tenofovir was about 1 log reduction, whereas at the highest dose of GS7340, you get a 1.7 log reduction. Quite extraordinary. Very potent drug. The dose-ranging trial using the 8, 25, and 40 milligram doses is shown in this next slide, and you can see that the plasma concentrations are as depicted here. The blue is the plasma concentration of tenofovir, and the green, yellow, and red represent the GS7340. And the thinking here is that plasma concentrations may correlate with toxicity, and therefore lower concentrations are desirable. And you can see that at the lowest dose, 8 milligrams, it's about a 98% reduction in the Cmax in terms of plasma concentrations. And yet intracellular concentrations at 8 milligrams are about the same as the parent drug tenofovir administered at 300 milligrams. And if you get up to the 40 or 25 milligrams, you get 7 to 20-fold increases in intracellular concentration. So the drug concentrates within cells, and that obviously is where the virus is. So studies are underway to look at the GS7340 as part of a combined single tablet regimens. The first one replaces tenofovir with the prodrug, so it's a comparison of the quad to the quad with GS7340 in place of tenofovir. The other one uses GS7340 with darunavir boosted by cobicistat regimen. It's the first time to have a protease inhibitor-based single tablet regimens. These studies are underway, and we eagerly look forward to their presentations at future scientific meetings. Finally, I just want to present 1 or 2 slides about drugs for treatment-experienced patients, since all the things we've talked about really will primarily target those who are starting therapy for the first time. We need drugs of this sort because persons who have treatment experience sometimes face very daunting attempts to control their virus, requiring multiple drugs, numerous potential side effects, many tablets taken many times per day, and it's just a very challenging thing, sometimes not even possible, to get a regimen that's sufficiently potent to suppress resistant virus. So we need drugs that are able to be effective in persons who have highly resistant viruses. But importantly, in the other parts of the world where access to therapy is much more limited, people who initiate a first regimen and then do not suppress virus often, because of very limited choices, have to stay on their initial regimen even though viral resistance has emerged. And unfortunately, the longer one stays on a failing regimen, the greater is the amount of resistance that accrues. So we need something to which a switch could be made more rapidly. And so to that end, the new attachment inhibitor that will work against virus attaching to CD4 positive cells is in study sponsored by Bristol Myers Squibb. The study is enrolling. In fact, is near completed its enrollment, and we look forward to presentation of the data. Rilpivirine, the non-nucleoside reverse transcriptase inhibitor that was approved in 2010, is now being investigated as a long-acting depot preparation that could potentially be given once every couple of weeks or even possibly once per month. Would be a very exciting development, could potentially simplify therapy in ways that could possibly be very advantageous. And finally, dolutegravir, the drug we showed very positive initial results for a few slides back, is also being investigated with a replacement to it that is the backup should the current dolutegravir prove to need improvement, and the backup looks like it also has a very long half-life, so this could potentially be quite valuable as well. So I think new agents for initial therapy, the quad is almost certainly going to be approved by the end of August 2012. About a year afterwards, dolutegravir will represent the third integrase inhibitor, and then simplification in terms of a low milligram medication, GS7340, to replace Tenofovir, and potentially reducing the risk of adverse events, I think would potentially be a very welcome addition. The new agents for treatment-experienced patients are fewer in number, but include the BMS attachment inhibitor and likely improved versions of dolutegravir as well. For future developments are obviously eagerly awaited. Well, without question, antiretroviral therapy has had an enormous impact on the population of people with HIV infection. A study published by the Journal of Infectious Diseases 6 years ago documented AIDS drugs having added 3 million life years to the population of persons who are HIV positive. These numbers are obviously much greater now, 6 years later. It's fair to say many millions of lives have been affected, life years have been added to persons who are HIV positive because of the availability of these drugs, and their effect on transmission and other favorable factors should not be underestimated. If we look at the fact that antiretroviral therapy is expensive and it does require a considerable investment, I think it's fair to compare the impact of antiretroviral therapy with other commonly accepted medical interventions. This slide looks at the survival gains of antiretroviral therapy compared to those seen with other highly frequently used interventions such as adjuvant chemotherapy in breast cancer, angioplasty for coronary artery disease or bypass graft, and bone marrow transplant for lymphoma, and ask the question, what is the impact of the intervention on survival in the population? These estimates, I think, are relatively accurate, but for antiretroviral therapy, it's important to note that these were estimates from more than 10 years ago. The quality of therapy in 2012, 2013 make that ART bar many-fold higher than it appears to be on this graph, and establish, I think, without question, that there may be no more impactful intervention than proper application of antiretroviral therapy for HIV-infected persons. My last slide reminds us that those of us who do healthcare must always remain a student of medicine, so that patients who come to see us will always get advantage of the most accurate and most informed opinions that are up to date. Half of what we have taught you is wrong. Unfortunately, we do not know which half. And quite obviously, when I look at lectures I gave about antiretroviral therapy from 10 years previously, the recommendations of that era now have been shown to be insufficient to the task, and the current recommendations represent the state of the art. But these will not always be the state of the art. So those of you who've spent some time today being hopefully educated about the current status of antiretroviral therapy will continue to remain committed to improving your education in that regard so that your patients, when they come to see you, will get advantage of the best, most up-to-date information we have on how to treat persons with HIV infection. I very much appreciate your investment of time. I hope this has been some value to you and look forward to talking with you at future conferences. Thanks very much.
Thank you very much, Dr. Hicks. That was a wonderful overview of this topic and will provide us with insights of the medications that are coming for our patients in the very near future. To those of you in the audience, we hope that this has been a worthwhile educational experience for you. We remind you to please complete your CME forms such that you can obtain credit for your activity. We look forward to having you with us for future sessions. And with that, we wish you pleasant days ahead. Thank you very much.